Now we move to the first session of this conference, which is dealing with the clinical aspects of Williams syndrome. Because of the fact that the first three speakers are Italian and most of the audience is formed by people living in Italy, we have suggested to give the first three lectures in Italian with the slide in English and the simultaneous translation. So I am happy now to introduce the first of the three speakers, which is Maria Cristina Digilio, which is chairing the Department of Medical Genetics in our hospital, the Bambino Gesù Children's Hospital, and her presentation is dealing with rare clinical feature of Williams syndrome. Quindi la dottoressa Digilio è la prima delle tre.
Digilio will hold the first of the three presentations named with the title Rare Clinical Features in Williams Syndrome. The other two presentations will be in Italian with the slides in English and the simultaneous translation in English. You have the floor. Thank you, Professor Dalla Piccola. I would like to thank the President and the Association for inviting me to participate. We are talking about the typical aspects, the typical features of Williams syndrome. There are many families, the parents know full well these features, and I would like to explain them as an introduction to talk about then the rare aspects, rare features of the syndrome. In the last few years, new or more sophisticated aspects are coming out, and it would be useful to know them in the management of Williams syndrome. The features are facial anomalies that are typical among the subjects, a developmental delay that varies on a case-by-case basis, congenital heart disease, they are prone to hypertension and hernia and strabismus. Of course, there's a huge clinical variability from subject to subject because not all patients with Williams syndrome have the same features, and every symptom is present in only a percentage of cases. You see the facial anomalies are constant with a variable expressiveness, and the developmental delay is described in 97% of the cases, congenital heart defect in 75 to 80% according to the case studies. The suspicion to hypertension is in 20%, and it comes from adolescence onwards, and 50% of the cases, and 40% strabismus and 40% hernia. The clinical expression of the syndrome is wide. We have a situation whereby if a child has the typical facial features and congenital heart disease, it's easy to make the diagnosis because there are features that lead the pediatrician and the specialist and the geneticist to think about this diagnosis. If the expression is atypical, the disease can be misdiagnosed. We use not only these signs for diagnostic purposes, but also for specialist follow-up checkups. And so beyond the typical features that will require the greatest effort, we will have to make an effort also to try and correct early some signs that are rarer, but we should consider the patient's diagnosis. For example, if we have a child that has a congenital heart defect such as supravalvular aortic stenosis or peripheral stenosis of the pulmonary arteries, of course, one immediately thinks about Williams syndrome because they're the typical features of Williams syndrome. And, for example, the supravalvular aortic stenosis is only with Williams syndromes. There are no other syndromes with this type of heart disease. So in the presence of a typical sign, there's an early diagnosis also in the first year of life when the heart disease is diagnosed. But there are also other rarer heart diseases. For example, when a geneticist sees the supravalvular aortic stenosis, if you see they immediately think about Williams syndrome, but aortic coarctation may be present in other diseases, but the etiology of this disease can be connected with Williams syndrome, and in particular with the gene within the deleted region that causes the heart disease, and it connected with heart disease, namely the elastin gene. So VAS, PPS, and aortic coarctation, that is a stricture of the aorta, they are connected with an elastin defect. So I would like to mention these twins. They have a mutation of the elastin gene, so the deleted region is there, but the gene within is broken at a segment. So these are identical monozygotic twins. They have the one has the typical features of Williams syndrome, and the other one has an atypical heart disease. This is a work from 2009, and so we did a review of congenital heart disease in our case studies, and it emerged that the preferential associations with the typical heart diseases were confirmed, but the strongest message for the discussion was that there's also a percentage that is not insignificant. We talk about 6 to 8%, also about rare heart diseases, for example, interventricular defect, that in some case studies is not even mentioned as association, and in combination is present in 8% of the cases, as the prolapse of the mitral valve, which is a heart disease that is to be followed over time because it can worsen. So the clinical message is to follow these patients closely, and it's the bicuspid aorta that doesn't even give the heart murmur, and it has to be monitored with echocardiogram because it can impair the flow of blood that goes through the valve. Of course, having other heart diseases, also old case studies were diagnosed on the typical sign. The new diagnoses rely also on atypical signs, and now more than in earlier years, a Williams syndrome patient does an echocardio, and so the heart disease is diagnosed even if earlier it wasn't known. The supravalvular aortic stenosis is associated with elastin deficit. Intraventricular defect is, we don't know how to connect it, but variations in the deleted region can cause these atypical signs. And we should not forget that this elastin defect, which is a vascular component, something that from a genetic viewpoint favors the stricture of vessels, can recall not only the heart and the vessels that start from the heart, but also other districts. For example, there are recent papers, 2012, 2014, and 2015, highlight an involvement at the eye level. So when you look at the eye closely, you may find a distinctive tortuosity of the arteriovenal circle of the vessels of the eye, or acute cases for gastrointestinal symptoms that proceeding with the ultrasound or more invasive tests documented some strictures to the abdominal aorta, or the vessels that start from the abdominal aorta. And at the heart level, the aortic stenosis is the most typical one, but also the coronary arteries may be subject to stenosis or aneurysm, and these factors are taken into consideration for monitoring. So when you do an echocardiography, you don't only check for the aorta, but also the valves and the other aspects of the heart connected with risk factors, because at the surgery level, one has to be prepared what the anatomical situation is to prevent complications that, if one doesn't know that there is a rare association, you may encounter at the vascular level. And also at the respiratory system, elastin can constrict the vessels. And so when you intubate a child for surgery, the vessels of the respiratory system may react differently. And there are individual signals of abnormal strictures, for example, cricopharyngeal achalasia. And so the esophagus and the gastrointestinal diseases, when children within 1 year of age have reflux. It's something functional and not anatomical, and it's called a stricture of the esophagus or the intestines. And so we think about the upper airways and the gastrointestinal system. And something less rare is celiac disease, and the percentage of cases, of William cases with celiac disease, is not high. It doesn't reach even 10%, so it cannot be considered as a strongly associated symptom, but it's much higher than in the general population, and this was seen comparing a prevalence of celiac disease in Williams syndrome in the Italian population. But what should be taken into consideration that is that celiac disease in Williams syndrome can give atypical symptoms such as gastrointestinal symptoms of the vomiting child as when he's a baby. Can also occur in absence of diarrhea or anorexia that are classically associated with celiac disease, but not with Williams syndrome. As was proven for other genetic diseases, there's a great proneness to this type of diseases, so they have to be screened over time. The opposite, namely, if you remember, the first signals of Williams disease say that hypercalcemia is one of the typical features, because in the 1960s it was described in all patients. I would like to go back in time for a while, because there may be cases of patients with hypercalcemia, but due to the changing in feeding and types of milks which are used at the commercial level with less calcium within, and the triggering of hypercalcemia no longer happens. So in modern case studies, this symptom is more rare. Thyroid, as you know, your children are monitored for the thyroid hormones every year. It's rare to have patients with congenital hypothyroidism, but we have subclinical hypothyroidism, so FT3 and FT3, the circulating hormones are normal. So it shows that the thyroid doesn't work very well, but can overcome this obstacle. So it's something that you keep under control, but it shouldn't be seen as something that necessarily would bring to a malfunctioning of the thyroid. Controversial symptoms in the last few years is epilepsy. There are rare cases, a percentage of cases that is less than 5% in Williams syndrome, of patients with epilepsy as well. In 2014, and a work with Giuseppe Merla from San Giovanni Rotondo came out that signaled cases in patients with atypical deletion, so with a deletion concerning the critical region for Williams syndrome, but not all of it, and a little bit shifted, so involving other genes as well, that had epilepsy. So it was thought that there might be some genes that could favor this symptom. It's this way because atypical deletions have this type of involvement, but the with recent work based on case studies with typical deletions, so that this symptoms of epilepsy is present in patients with typical deletions. So it shouldn't be necessarily associated with atypical deletions, but if there is a symptom that might make you think it, you should hear from your neurologist to do an EEG and do the other tests. With reference to the complexity of genetics in the last few years, so we have new molecular techniques, and we found situations that are complex, meaning that if we have a typical case of Williams syndrome, of course we can think that it's all connected with the deletion of chromosome 7, but if we find some symptoms that are not compatible, so we have Williams syndrome, but there's something that we don't understand, it might be worthy to extend genetic testing because we may find something else associated, and this other association may pave the way for further controls that normally aren't done for Williams syndrome. This is a recent report with XYY situation that predisposes to mental retardation similar to the one in Williams syndrome. And this is a case of patients with Williams syndrome and a microdeletion in another chromosome. So there's microdeletions and the lack of microsegments in two different segments. So as if the child was predisposed to the event of microdeletion that was identified because the patient had features of both syndromes. And recently we had a case with a deletion for Williams syndrome and also a mutation of a gene that causes Kabuki syndrome, because they had the facial features of Williams syndrome, but she had a heart defect that was never described in Williams syndrome. And the message is that if we have a more complex situation compared with what we have, we should consider that we have multiple genetic defects, and we should assess them. Thank you for your attention.